Hello and welcome everyone to the first Forever Healthy online meetup in 2021. We are really happy that you are all here today. And because we had a lot of new members in our meetup group, I take a brief minute to explain what's going to happen today. So we're going to have the opening remarks as usual by the founder of Forever Healthy, Michael Grebe. And then afterwards, I'm going to present our risk and benefit analysis on vascular rejuvenation using EDTA. And then finally, I'm gonna properly introduce our guest speaker, Dr. Gervasio A Lamas. We are really happy. Thank you very much for taking the time to being here today. We are gonna have a Q&A session and then breakout rooms. For everyone who wasn't here before, breakout rooms was something that we invented last year because we were all craving a little community in this difficult times. You will be distributed with 5 people in separate chat rooms where you have a few minutes to get to know each other. And then we're going to meet here again for the closing remarks. You don't have to join, but yeah, you can stay if you want to. And with that, we get officially started with Michael's opening remarks.
Thank you, Isabel. I'm just quickly start my sharing the screen. Oops, that's of course not what I want. There we go. So welcome everybody to our online meetup. For those of you who don't know what Forever Healthy is doing, I just want to give a quick introduction about our foundation and the work that we do. So, great. So, Forever Healthy, we are a private non-profit initiative. We are funded privately with my, I'm financing the whole mission and what we are doing. Our mission is to enable people to vastly extend their healthy lifespan. So what does this mean? Imagine we could immediately improve our well-being. Imagine we could directly reverse chronic diseases such as heart disease or arteriosclerosis or any other degenerative disease. And my personal goal is imagine we could be as healthy at the age of 70 as we were at the age of 30. And imagine we could stay free of the diseases of aging for almost all of our life. And imagine we could extend our healthy lifespan by decades or even longer. And totally amazingly, there's a still silent revolution going on. And the world really has taken the first steps and started transitioning from a world where we're completely helpless about our aging process and age-related diseases to one where aging is under full medical control and age-related diseases are just something of the dark past. Of course, we are not there yet, but the good news is that the theoretical groundwork, so what has to be done, has already been done. Research in this young field is accelerating. Of course, there could be more. And the first drugs and therapies that actually can slow down or even reverse some aspects of our aging process are already under development. And most amazingly, the first generation of rejuvenation therapies are already available today. So if you're a bit closer to the field, it is clear to us that it's not a question if this is going to happen, but when this is going to happen. And this is exactly the mission that Forever Healthy has. We want to accelerate this transition to a world without aging and age-related diseases. We do have, in order to achieve this, we do have a dual approach. On the one hand, we want to accelerate the future. We have 3 major initiatives in this area. The first one is our annual, or at least it's supposed to be an annual conference. Thanks to COVID, it does not happen last year and not this year. We hope to have it again next year in 2022 in Berlin. It's an annual conference, and it's solely focused on actual human rejuvenation therapies. It is for scientists, for startups, but also media and the interested general public is invited. So the last one that we had more than 500 visitors there and was hugely successful. Our second initiative in that area is we are funding research on the basically molecular and cellular repair of the damage that the body does to itself while it's aging, and to repair that. We have funded more than 10 research projects in that area, and we keep on doing so in the foreseeable future. And the third initiative for accelerating the future is we are supporting startups that take that basic research and turn it into actual therapies for human use. We have invested in more than 10 startups so far, and we have several major investments. And just to give you an example of what we're doing, our portfolio company, Underdog, is working on reversing a plaque in the arteries. And if we succeed, we will make heart attacks and strokes a thing of the dark past. Our portfolio company, Revel, that we help to bring into life, works on breaking protein glycation of proteins, protein crosslinks, and reverse skin aging and tissue aging doing that. And the third investment, a major investment that we just announced, Selby. Selby is set out to be the market leader and the technology leader in what we call therapeutical mitochondrial transfer, that is taking young, super healthy, energetic mitochondria and transplanting them into recipients, and thus really bringing aged molecular processes back to a youthful state. On the other hand, we want to help people use of what is available today. I mentioned there's already some rejuvenation therapies available, and we have the Rejuvenation Now initiative that seeks to continuously identify new potential rejuvenation therapies, analyze what scientific backing is there for these therapies, and then to systematically evaluate them, and then do what we call risk and benefit analysis and publish that on our website. Our second initiative is called Maximizing Health, and Maximizing Health wants to make the vast amount of advanced medical knowledge that's already available today, but unfortunately inaccessible because it's deeply buried in research, in books, and in scientific special communities or specialists, unearth that knowledge and turn it into an actionable form and make it also available. And our third initiative in that area is what we call our longevity strategy. The longevity strategy ties together the information from the knowledge and the results from Rejuvenation Now, Maximizing Health, and selected experts in an easy to follow step-by-step guide on how to actually improve one's health and extend one's healthy lifespan. So these are 6 main initiatives. We are growing in that. We are looking for people to support us. We are hiring researchers and medical doctors, that particularly for the Rejuvenation Now and Maximizing Health initiative. So if this is something that interests you, or you know somebody who might be interested in that, feel free to apply. So short overview finished, and back to Isabel. Thank you for your attention.
Thank you, Michael.
I stop sharing my screen. Yeah. Okay, back to Isabel.
Thank you for giving this overview about all the exciting things that we do at Forever Healthy. Then I gonna share my screen now, and we jump into the scientific part of today. Sorry, multitasking. Okay, so my name is Isabel. I'm the scientific spokesperson of Forever Healthy, and Michael introduced our initiatives already, and I want to stretch one more time that really one of our main mission is to make knowledge accessible. As he mentioned, a lot of scientific data is buried and some journals behind paywalls, and the treatments or methods that are already available are mostly available on a cowboy style market. That's how we call it. So the service offerings are profit driven. There is no trusted source of information. You don't find references to clinical trials that show really benefits in humans, and there is no focus on risks and risk management. So we really want to give you the key to your own health by making the knowledge about those treatments available and accessible open access on our website. Okay, let's jump into today's topic, EDTA chelation. For those of you who never heard about this, EDTA is a synthetic amino acid that can chelate metals. So what's chelation? Chelation is a reversible binding of a chelator like EDTA to a metal ion. It forms a complex, and this can then be excreted by the liver and or the kidney. And for illustration, I put this magnet here on the left side. So you can imagine EDTA being a little magnet that can bind, for example, lead or cadmium or calcium, and then can be excreted. So EDTA is already an approved medication, for example, for lead poisoning, but it also has an off-label use to prevent or reverse cardiovascular or chronic disease. But this is a debated topic, and so we as Forever Healthy really wanted to dig into the scientific clinical trials that are already out there to evaluate if EDTA is a treatment that is, a treatment that can be used for vascular rejuvenation. So what we did is we screened more than 2,000 papers and evaluated 111 suitable clinical trials, identified 54 benefits and 21 risks, and everything is published open access on our website. So the aims that we are always having when we are doing our research is to identify the benefits for use in humans, and also what are the potential risks and how can we mitigate the risks. And then eventually we come to find the best therapeutical protocol that's currently available. And one very important factor, so we have a method where we weigh the criteria that we find on a value scale to enable comparison from 1 to 3, and then the weights and scores are multiplied for direct comparison. So at the end, we have a scale from -3 to +3 if we recommend something or not. And a very important factor in this is the quality of clinical trials. And we included 111 trials, and a lot of them were observational studies that that get a lower score because observational studies are mostly retrospective. We observed a treatment that was done before, and then in retrospective, we're going to look at what was the effect. A bit of a better design is an open label study. Open label means that the doctor as well as the patient, so everyone involved in the study, really knows who gets the therapy, who gets the placebo. And a lot of the studies that we found didn't even have a placebo control group. So a gold standard and a very good clinical trial, we consider it a good clinical trial is a randomized control trial. Here, the little dices on the picture means that the patients that are enrolled are really randomized into the therapy and the placebo group, and neither the doctor nor the patient knows what treatment they are getting. So we reduce a lot of bias. And here I want to highlight especially one particular study, the TACT. TACT stands for Trial to Assess Chelation Therapy. This is the largest study that has been done in the field. It's a multi-center, double-blind, randomized controlled trial that took more than 10 years to be conducted. So teaser alert, we are really, really happy today that we got the principal investigator of the study, Dr. Gervasio A Lamas, here today, and really an expert in the field to give us more insight about the results of the TACT trial, and also about the follow-up of the TACT-2 trial later on. So what we did, benefits that we identify, I told you before we identified 54, but here just to highlight a few with a score of 3. So the best score that we can give on our ranking system is decreased cardiovascular adverse events, increased kidney function, and something that really stood out is decreased symptoms of peripheral arterial disease. If you don't know what it is, I know that Dr. Lamas will talk about this in more detail in the next presentation and has really stunning results on that. We also found its benefits, decreased lead and cadmium levels and decreased symptoms of angina. But what are the risks? So is this therapy really safe? And the main risks that we found are low calcium levels, low blood pressure, low blood sugar, and depletion of essential minerals. You can see on the score it's -1, so it's the lowest score that we could give, which means all those risks are transient, reversible. They only happen during or shortly after the treatment itself, and they could be fully prevented. So what is our conclusion for EDTA for vascular rejuvenation? The benefits clearly outweigh the risks in more than 100 clinical trials, including the TACT that we considered in our analysis. It's very important to choose a qualified physician. It's important to do a proper pre and post medical examination. The risks that I mentioned on the slide before can be prohibited if you adjust the dose and the infusion rate, and also supplement vitamins and essential minerals. So the full analysis and all references that we used, and including the protocol, can be found under brain.foreverhealthy.org. And with that, I also want to end with the join the team slide, because if you feel now, wow, I'm a MD or PhD and I would really like to make knowledge available, then join the team, because we are looking for new team members. And with that, I'm also gonna stop share. And now introduce finally our guest speaker, Dr. Gervasio A Lamas. We're very excited that you are here today. Dr. Lamas is chair of medicine and chief of cardiology at the Mount Sinai Medical Center in Florida. So I see it's daylight out there. You said it's really quite warm and nice. He has a very interesting journey. I think you came into the field of EDTA in 1997 when a patient asked you about the therapy, and you decided to do this gigantic clinical trial of 10 years to actually disprove that it works. And then you yourself were stunned by the results. And I think this is really impressive. And I know what you're talking about today, and I'm really, really excited about your presentation.
Thank you very much. And I want to thank you, Isabel, for the opportunity, and Michael, for the opportunity to speak with individuals who are interested in this subject. The idea of improving healthy lifespan is one that I've come to as a cardiologist, but I've come to realize that we have many exposures to different things, different elements, pollutants, and so on, that take years off of our life. And this metal contaminants in the environment is just one of them. And let's just talk about that a little bit. Hang on, let me advance. Here we are. There we go. So there is extensive epidemiological evidence showing that there is adverse cardiovascular effects of metals. And again, remember, this is going to be very cardiovascular focused because I'm a cardiologist, and so I feel most comfortable talking about this, but we can drift a bit in the question and answer. I put two arrows on the ones that are easiest to remove from the body, cadmium and lead. And those are removed by EDTA. Now, is there anything new that I'm going to be telling you? Well, no, not really. The first publication of lead causing atherosclerosis was in 1886. So that lead has been known to be a vascular poison for decades and decades and centuries. Now, going more recently, 2018, I'm not going to expect you to read this because it looks like microfilm and the methodology is really quite opaque, but the summary of this paper in Lancet Public Health, which is really a great journal is, and this is based, the methodology is based on a survey population, a study population of many thousands in the US that are selected to represent the entire United States. So the lead attributable risk of all-cause mortality accounts for 18% of deaths, nearly 500,000 deaths annually due to low-level lead intoxication. These aren't lead miners. These are people like you and me. Cardiovascular disease mortality, 37%, 256,000 deaths annually. Ischemic heart disease, 28% of those, 185,000 deaths annually. This is a staggering cost of low-level lead in our environment, which gets in the body and has a very, very long half-life. Different study from the same kind of population that was looked at. And we're looking at environment-wide association study for risk factors for peripheral arterial disease. So when you talk about heart attacks, you're talking about coronary artery disease, or coronary arteries are the arteries that supply blood to the heart. The peripheral arteries supply blood to the brain and supply blood to the legs and arms. But this really reflects the legs, usually, when you talk about peripheral artery disease. And let me go back, because it zipped by. And 4 significant risk factors in a very complex multivariable model. Cadmium was number 1. Cadmium, again, a known toxic metal. This study also in 2018. 2018 was a great year for epidemiological studies of lead intoxication. This study looked at multiple different other studies that have been done and put them together as a systematic review. They looked at 37 studies with 348,000 patients. This is big. Exposure to arsenic, lead, cadmium, and copper was associated with an increased risk of cardiovascular disease and coronary disease specifically. A linear dose-response relationship was associated with arsenic, lead, and cadmium. What does that mean? That means that whenever you do an experiment and you find that something is associated with this disease, it would make sense that if you get more of that something, there'd be more of that disease. It's an internal test of validity. And that internal test of validity was passed by arsenic, lead, and cadmium. So lead is associated with hypertension, stroke, myocardial infarction, and mortality. Its principal storage is in bone. Once in bone, the half-life is about 30 years. Cadmium is associated with coronary disease, cerebral vascular disease, that is strokes, and particular peripheral artery disease of the long arteries that go to the legs and of the tiny arteries that go to the toes and feet. Principal storage is in kidneys, liver, and lungs. Half-life is 30 years. And there's strong mechanistic and experimental evidence supporting these vascular toxic effects. We don't have time to go through that, but I assure you, it's there. The references are there, and you can look at them later. What happens if I give you 3 grams of edetate disodium, or EDTA, the sodium salt of it, and check what's coming out in the urine? This is, this on the panel on the left is lead. Baseline, there's only a teensy little amount of lead. We're not built to excrete lead. If I give you placebo, it's about the same.
Can I quickly interrupt you? We were asked if you could maybe use the slideshow, because the graphs are a bit small, so that we can see it a bit bigger. That would be awesome.
Of course. I thought I was using the slideshow. Let me see. I may be sharing then the wrong screen. Let's look.
It looks like there's a use slideshow button at the top.
Swap displays, maybe?
The to the right, the icon to the
Right
right.
there, that's good.
Yes.
Yeah, let's do that. Let's do that.
Perfect. Thank you very much.
Is that better?
Yes, that's better. Thank you.
Okay, good. Do you want to go, are there any slides that you want me to go back and look at?
I think for now, because now the data is starting, so I think it's good that we started now to have a full impression of the data.
Very good. So what happens if I give you 3 grams of EDTA and see what comes out in your urine? Now, EDTA is 90 to 95% excreted in the urine. So at baseline, there's very little lead. This panel is lead. At baseline, there's very little lead. If I give you the same volume, but just make it salt water, placebo, there's, again, nothing happens. And if I give you the EDTA, what happens? An average 3,800% increase in the amount of lead you put out. So these are all men who are in Miami and are at least 50 years of age and have coronary disease. We do not have any lead mines in Miami. This is what we all carry around with us. Cadmium, about a 700% increase. These are 2 poisons that have no role in our body. Now, how about treating heart disease with EDTA? Has that been successful? Well, it turns out that the first study that was done, again, was not new. It was done in 1956. They treated 20 patients who had severe chest pains, and in fact, those patients ended up getting better. So comes 1999, a patient walks into my office. I'm a practicing cardiologist, and says that he wants EDTA chelation. And I told him that it was nonsense, that it was expensive, that it didn't work, and that he should take the medicines that I gave him, which were a beta blocker and a statin, and that would be enough. And then I started thinking about it. I looked up the literature, and not unlike Dr. Schiffer, I found out that I could not really support what I said. I couldn't support otherwise either. And that started a journey that goes on till now. That was in August of 1999. And the first large step in that journey was the trial to assess chelation therapy, where I was able to get a $30 million grant from the National Institutes of Health. We looked at patients who were age 50 or older. They'd had a heart attack at least 6 weeks prior. And creatinine was consistent with, at worst, moderate kidney function. Just in terms of the relevance, this is a very US-centric slide, but we have about 600,000 new myocardial infarction survivors annually in the US, and about 200,000 of them have diabetes. The vital stats of the study were a $30 million study. It lasted 10 years, 1,708 patients in the US and Canada, 134 sites, and 55,222 infusions were given to our patients. The study was designed as a factorial trial because I found when I started looking into this, really I knew nothing about EDTA chelation. I found that patients also received oral high-dose vitamins. That would be a subject for a different conference, which if you want, I'm happy to do at some point. But we're really going to be looking at IV chelation in blue versus IV placebo. Factorial trials are very powerful because, as you can see here, we can do, if you look at light blue versus orange, you can look at oral high-dose vitamins versus oral placebo. And what's most interesting to me, of course, is the patients in orange, in the orange block here. This is the patient who is a good patient for a conventional cardiologist, right? They don't take vitamins and they don't take EDTA. Placebo, placebo. And these patients are the ones that leave my office, take a left turn, go to the chelation practitioner, and don't tell me about it. And they are receiving active. So that's a different issue. What did we give the patients? We gave 40 infusions, roughly a week apart. The first 30 were given a week apart, and the last 10 were given 2 weeks to 2 months apart. So it worked out about a month apart. The active infusion had 3 grams of EDTA, 7 grams of ascorbic acid, electrolytes, B vitamins, a little heparin, and some procaine. The placebo infusions were primarily normal saline. And as I said, we gave a lot of infusions. The oral vitamins were 28 components. But again, we're sticking up here. We can talk about later as to why this was such a mix of different components. The primary endpoint, remember, everybody's had a heart attack, so they all have established coronary disease. The primary endpoint is death, another heart attack, stroke, coronary revascularization, that's coronary bypass surgery or a stent, or a hospitalization for chest pains. The baseline characteristics of our patients, you can see the average age is about 65. There weren't that many women. Over a third were diabetic patients. About 3/4 were on statins, and over 90% were on some type of blood thinner to reduce coagulation. And this is what I presented. The grant was given to us, the $30 million in 2002. We finished in 2012. And I presented this in November of 2012 to the American Heart Association in a large room with about 5,000 people. And as you can see, the placebo group has more events than the active treatment group, and it meets conventional criteria for statistical significance. Well, when I showed this, because cardiologists always think that EDTA chelation is nonsense, the entire room sucked on air. They all went, because they were not happy about this at all. And in fact, the convention newspaper on the next day from the American Heart Association with dismay greets positive chelation study. So this showed me how much against the current one had to swim in order to get to a point where cardiologists would feel that lead and cadmium are toxic and that removing them will improve cardiovascular outcomes. We analyzed patients with diabetes and we pre-specified it. It's important that you always do pre-specified endpoints and that those are the ones that you present. Anything else is speculative. So let's look at the diabetic patients. Again, primary endpoint is that combined clinical endpoint. You can see that more patients have events. That's number one. And number two, you can see that the effect of EDTA chelation in green is absolutely spectacular. There's a relative risk reduction of 45%, 41%. That's extraordinary. There's nothing like this in diabetes. Nothing like this in diabetes. And this is with a treatment that does not control blood sugar, which is really what is fascinating about it, one of the most fascinating things about it. But the story gets even more interesting. Let's look at the diabetics and the non-diabetics. You can see that the non-diabetics obviously have fewer events. We all know it's bad for the arteries to have diabetes. And these are the diabetics. The patients with diabetes and who have been treated with chelation look very similar to those who don't have diabetes. They look so similar, in fact, that it is as if we were able to remove the effect of diabetes from these patients with atherosclerosis, with a prior heart attack, as you can see. What about the holy grail of clinical trials? Total mortality. At the end of it all, how many people are alive at the end of 5 years? We found that we were able to reduce the risk of death by 43% in patients receiving EDTA in diabetes. The p-value again met conventional criteria for significance. This again is something that you do not see with anything else, any other therapy. This extent of efficacy. Let's look at some of the components of the endpoint in the diabetic patients. Cardiovascular death, MI, or stroke are what we call the irreversible components. Reduction by 40%. Recurrent heart attacks reduced by 50%, roughly. Reduction of stents and coronary bypass reduced by a third. Again, an extraordinarily effective and safe treatment. So how do we interpret these findings and what are the next steps? Well, I think we need to consider it likely that toxic metal pollutants are a modifiable risk factor for cardiovascular disease, and staying in the same wavelength as this organization, that this is an important target to have a long, healthy life. We need to focus on TACT as heralding the potential rise of a disruptive pharmacology. Why disruptive? Because we are not treating toxins, environmentally acquired toxins, as we should, because they shorten our life. How do we get there? Well, we have to replicate clinical results in the population with diabetes and prior MI, because in science you replicate. You have to do things twice. And we need to really work out the mechanisms, particularly the metal and oxidative stress hypotheses that we developed or really backed into after the study was complete. I went to the FDA, the Food and Drug Administration, in 2014. It took us 2 years really at this, because I have to tell you, after 10 years of doing this study, I truly expected it would be negative. And so the statisticians unblind the study for us, to give us a study book. We look at it, and the first thing I said was, "You're kidding. This study is positive?" And the answer was yes. So 2 years later, we published 2 or 3 papers, and we go to FDA. The study was done under FDA supervision and with an FDA license. And they said they agreed the study was positive. The drug was safe. They would not discourage our applying to get this drug into the mainstream. That's called a new drug application. But they said, but this is EDTA. This is only one study. The committee is cardiologists. They will probably reject it. And then all that anyone will remember is that EDTA was rejected again. We really prefer that you do this again. And by the way, let's work out the mechanisms, and why don't you do it in patients with diabetes? And so comes TACT 2. That was September 27th, 2016. We received a grant of $36 million to do a replicative trial of IV chelation and oral vitamins in post-MI diabetic patients. We have a strong mechanistic component. We have a focus on toxic metals. We have a biorepository from every patient. TACT 2 is happening. On 12/31/20, just a month ago, we enrolled our 1,000th patient in the study, and that was the last day we could enroll. So on the last day, we got to 1,000. I think that that's a very good omen. In the meantime, of course, this study is running, one gets bored. So I thought that it would be very good to look at peripheral artery disease, because chelation practitioners always said that they could treat diabetic vascular disease. And this is a terrible disease. Diabetic patients, long-term diabetic patients, they have severe atherosclerosis of their legs, and their feet have to be amputated very often. It's really a tragic, tragic illness. So we published this in an open label journal. And by the way, everything else that I've published, I've paid whatever I have to pay in order to have it be open label, because we're not Pfizer, and we can't take out ads on TV as we do in the US, or put out ads in newspapers or magazines. You have to read about it, and you have to be open label. So this is a patient, our first patient in this particular study. And before I take you upstairs, up to the top, let me just look down here. This is how much lead was taken out after the first infusion. The amount of lead was 8,000% greater than baseline. This is an elderly woman who has never been a lead miner. She's lived in Miami all her life. 8,000%. This woman is retaining lead tremendously. Cadmium, 1,000% more. So she has already lost, she's a type 1 diabetic, she has lost all 4 toes in this foot, and she has gangrene of the big toe. This is after 21 infusion, and this is after infusion 45. Baseline, she also had this sore. So she was pretty sure she was going to lose the forefoot, the front of the foot here. I saw this lady a week ago, and she is still walking, and she still has her foot. So this is years, 5 years later. It's extraordinary. This disease doesn't do this. It doesn't stop. This individual already had had an amputation of his second toe, and he had an ulcer there. You see this redness and shiny look. This actually means that circulation is poor. Infusion 20, infusion 50. 5,000%, 6,000% greater amount of lead after his first infusion. No ulcer here. Here's the picture with the ulcer and the redness, and here we are. So this gentleman I see him as a patient, and he's doing quite well. Both feet are on, no more vascular surgery, and this is many years after his last EDTA infusion. This patient is the one that truly, truly convinced me. Let's go forward. Yeah, this is the one who really, truly convinced me. This gentleman had gangrene, had multiple procedures to try to restore blood flow. They couldn't. So this black scar, S-char it's called, is dry gangrene. So the foot is dying. At this point, he was scheduled for a below the knee amputation, so it'd be somewhere mid-calf. In 2 weeks was his operative date. The wife had heard that I was doing some experiments and asked me about it. I said, we're trying to see what this does, if anything. This is infusion 20. You can see that the ulcers are less. This is infusion 48. It healed. You can see the scar where this ulcer was located. There was nothing else was done to him. He still has his foot. The wife refused to stop giving him EDTA, and she is getting EDTA monthly from a private practitioner. This is a different perspective. This is from above. You can see how badly the big toe is affected. And here, it is as if new tissue were regenerating where none should be. This one was a little bit destroyed, but at the end of it all, he has his foot. If you do an amputation of a leg, and an 80-year-old, which is what he was, their life is over. This was almost 4 years ago, and this gentleman is walking around. So where are we now? Well, TACT, complete, post-MI, and cardiovascular endpoints. We looked at it in detail. TACT 2 is half done. Double blind, I have no idea. Post-MI cardiovascular endpoints in diabetes. TACT 3A is a 50-patient study in PAD, in peripheral artery disease with critical limb ischemia, gangrene or near gangrene in diabetic patients. That one's blinded, but we're getting there. The pandemic obviously interferes with enrollment. TACT 3 would be a peripheral artery disease study if this one is positive. And I think that we need to look at cognitive function, because some of my patients in the peripheral artery disease study had clinically improved cognitive function. So let's end with that. I want to thank all of you for coming to this meetup, and particularly Dr. Schiffer and the Forever Healthy Foundation. I think that we have very similar goals, and I'm very happy to have made contact and met you, and honored to present.
Yeah, thank you very much, Gervasio, for being here today and speaking to us. I will say officially goodbye, because now we are ending the recording and now we are going over to the Q&A. Thank you very much for joining us.